On where we're started, we still got a lot to cover today. You have your exams next week. Whatever I don't cover, I want you to listen on to in the Camtasia session. You're still being responsible for it. Okay, so just do the best I can to cover as much as I can today. What I've done with these lectures is I have expanded them a little bit, so I'm going over a little bit on my time allotted, but I still think I'm trying to be more clinical based, so you guys are getting ready for your exams. And you're getting ready for clinical. Now, defibrillation monitoring or management is something that you do need to know how to use. Okay, how many of you actually have had a defibrillated patient? Okay, so almost everybody. That's good. Okay, that takes a little bit of the fear away. The first time you do it, you always think you can shock yourself in the process, and I've seen somebody do that to themselves. So make sure you always keep your body away from the patient and away from metal bars that are attached to the patient. So they can have some significant deleterious effects to you. Know how to use the defibrillator. You should know where the defibrillator is in every hospital that you work at, because you might have to go get it. Okay? Usually it's in a very obvious place when you walk in. Usually you can see it. But some hospitals will have it somewhere put away, and you have to know where it's at. Okay? Now, what the defibrillator is supposed to be done every day is supposed to be checked. Okay? There's a log sheet that should be upkept every day. So one of the things that I would do just to find out how well managed the anesthesia group is just walk over, look at the defibrillator, and look at their notepad and see if somebody's tracking it every day and signing off on it. Okay? If nobody's doing that, run. Okay? Because they're not even monitoring their emergency equipment. Okay? So that's the minimum you should look at. Okay? The other thing that I would look at too is when you're seeing how they're be careful with the defibrillators, because they're capacitors, okay? And what will happen to those things is that somebody will have it charged and they will not have fired it. And they had a death about, I don't know, several years ago now. When I was a medical student, they had a medical student up in Gainesville who decided he was playing with the defibrillator and he applied it to his head and pressed the buttons. Unfortunately, the capacitor was fully charged and killed him instantaneously. So don't ever play with this stuff. It is dangerous. Okay. The modern ones that we have, we used to apply jelly to the paddles when we used to fire it. Okay. Instead, now we have gel pads, which are a lot more efficient. Okay. They have to give you a nice thickness in the actual, and lets the electricity travel much better through it. The original defibrillators were monophasic. We now have almost everywhere biphasic machines. As to how effective they are, it gives you a much more, supposedly much more effective voltage delivery to the patient, so or joule delivery. So it works pretty well. Select the energy level. Usually, when you're having to use this, you're using 360 joules most of the time, unless you're doing something else. But make sure you press the paddles firmly onto the patient's chest. Okay, press the charge button. And then make sure that everybody's clear after the defibrillation tone goes off. Do not discharge the button, okay, until you say clear. Okay? And give people a chance to move away. I've had at least 3 of my fellow colleagues shocked by accident by the person who's defibrillating. Some people don't even care. They see that you put the paddles onto the chest. They feel like, well, I'm not just say, firing or charging or whatever else I want to say. They just fire it off, okay, and you're doing the airway. Now, if you're wearing a glove, you may be grounded enough that you may not get the charge, but if you're wearing bare hands, you're going to feel it. Okay, 1 or 2 CRNAs were working on somebody that I was working with, and I could see the guy was charging it. Didn't even have the paddles on the patient. He just charged it directly on the machine. And then when he was ready, he just came over with the paddles, didn't say anything, and fired it. Right before I could even grab the 2 CRNAs, one got 360 joules right directly through her hands, and she was against the wall. And the other one got partially shocked. So she didn't defibrillate. She didn't fibrillate, thank goodness, but she ended up being in the ICU for overnight. Okay? So make sure that you clear from people. These guys are idiots sometimes. Especially in emergency situations, some people are not thinking, they're just reacting. It's also explosive danger. There's been several reported cases. I saw this happen as well. Somebody was doused with gasoline from being in a vehicle, and they fibrillated, and they mostly from the fumes and hypoxia, defibrillated. So en route in the paramedic truck, they fired off one of the paddles, and it ignited the patient, okay, inside the ambulance. The paramedics almost died in the process, so it's something that can be potentially dangerous to you as well in the trauma bay. So just be aware of that. Okay, this is not a joke. If you smell gasoline and you have to defibrillate somebody, it's very dangerous. The other thing where you actually see it also happening is when people do alcohol preps. There'll be fumes underneath the drapes. And if you fire somebody off like that too, you can cause a spark and cause that effect as well. Okay, so that's just something to be aware of. Handling precautions, keep the battery in full charge at all times. Clean the pads after discharging them. Don't twist or warp the actual cables. You see that happen quite often, and that usually will actually cause a break in the line, and then that could be potentially dangerous to you. Okay? And one of the things that we do a lot in our cath labs is what we call radiofrequency ablation. We've had a great number of WPW patients. The number seems to be increasing to me. At least we're seeing it much more frequently. It's either is that we're seeing it more because we have the ability to ablate these, or people are actually being able to diagnose them a little bit better nowadays. Or maybe we were sending all these patients off to somewhere else and we never saw them. But we are seeing a lot more of them. So WPW is something you can do, radiofrequency ablation. These catheters are put inside the heart, and they use mapping to identify where the accessory pathway is. And then they actually burn that accessory pathway and basically kill the dysrhythmia from returning. So it's mostly for reentrant supraventricular dysrhythmias, such as WPW. And sometimes they're also used with ventricular dysrhythmias. If somebody is going to have to do radiofrequency catheter ablation with ventricular dysrhythmias, that means they're actually going to have to put the catheter inside the ventricle, and they're going to burn it. Okay, so just be aware that some of the problems with this is that it can actually burn right through the muscle, and that's happened. In the atrium, not a big deal, lower pressure system. Most of the time people can tolerate that. You'll get a small ASD or something, and that's all. But if you're burning through a ventricle, sometimes you'll go right through and develop pericardial tamponade and get yourself in big trouble. Most of these times, these people are done under conscious sedation, but things can go really wrong very quickly. If all of a sudden you go from a patient who's awake and talking to you, and all of a sudden says, I don't feel good, I'm feeling confused, I don't feel good, and they'll start talking gibberish, and of course they'll blame anesthesia. Say, what do you guys give to the patient? I didn't give anything. So usually that's a bad sign. Okay? If you haven't given anything, somebody's getting bad on you, that means something bad just happened from the procedure. Okay? It could be that you just tore through the aorta. Could be that you're got a pericardial tamponade now. So you got to be a little bit. You got to look at your rhythm. It could be that the heart rate's down at 30. Okay, that'll make you unconscious in about 10 seconds. Okay, if you don't get enough perfusion to the brain, within 10 seconds you're out. You're out. Okay, so if you see confusion levels, always think perfusion, confusion, perfusion. Okay, so make sure that the person's perfusing their brain. Now you have artificial cardiac pacemakers, when we do a lot of that as well. And I always kind of joke around with my other classmates and my workmates that I think Naples in about 100 years will be a site where somebody will be looking for lithium batteries in everybody's grave, because I think we're putting literally a pacemaker in everybody. So these kind of pacemakers are very functional in the sense they keep people alive for long periods of time, but they are expensive, to say the least. Okay? There's different forms of cardiac pacemakers that we use. In emergency situations, we can use transcutaneous cardiac pacing. If you've ever seen that done, you know it's uncomfortable. For the people who have not seen it done, if you have somebody who's awake who's being transcutaneously paced, they're not going to be real happy. Okay? So make sure that if you do have somebody that's awake, try to give them a little bit of Versed to try to give them a little bit loss of memory of this event. Okay? But it can be very significantly life-saving, so don't hesitate in using it if you're desperate. Okay? The patients can become symptomatically bradycardic, which means that their person is actually becoming unconscious or becoming confused. Okay? It could be from a severe conduction block requiring immediate pacing. The recommended treatment is for basically symptomatic bradyarrhythmias with a pulse. Okay, if you don't have a pulse at that point, you're going into CPR, so it's not a different scenario. The cutaneous chest and back electrodes should be placed over the areas of lesser skeletal muscle mass, okay, and low density constant current impulses should be delivered. Okay. It should be considered a temporizing measure until transvenous pacing can be instituted. Okay, you can see this is somebody who's have a transcutaneous pacing. Okay. That guy's going to be really sore, to say the least. Okay. And believe it or not, you can see it in some very young people where we've had to do transcutaneous pacing. A lot of times these can be induced by viral cardiomyopathies. Somebody can get a significant infection from a virus, and then all of a sudden their heart begins to dilate, and they go into a severe bradyarrhythmia. You have, of course, your permanently implanted cardiac pacemakers. The cool thing about them is they used to be the size of a hockey puck in the old days, okay, which was about 17 years ago. They were huge. They're about that big and about that thick. Okay? Now their size basically about the size of a quarter. Okay? So it's pretty small. It's pretty amazing technology. And what takes up most of the space, believe it or not, is a battery. Okay? Most of the electronics are microcircuitry now, so it's so very, very small. Okay? The great thing about this is you have a great amount of capability with these too. They can be reprogrammed on the fly using different reprogramming devices. The downside to them is that you can reprogram them as well by accident. Okay? Usually not very often anymore because they're shielded, okay? But electrocautery is notorious for causing sometimes these pacemakers to basically reprogram themselves. Some of the new manufacturers are saying that, well, that doesn't happen anymore as much. But you know what? Every time you read the literature, what does it say at the end of the literature? Make sure that you check every time that the pacemaker is functioning before discharge from the hospital recovery room. So they're telling you one word. They're telling you, look, you know, it doesn't reprogram, so don't worry about it. Okay. But then if something happens to the patient, okay, they pull out their little piece of paper and they show it to the lawyer. Says, you see, we told the doctor to check. He decided not to. Okay. So they got you. Okay. So in other words, because they wrote that in their literature, guess what happens before a patient leaves anybody from a recovery room that has a pacemaker? It's just had a surgical procedure. The rep gets a phone call, and the rep comes in and checks the pacemaker, period. Okay? Until they change that, and they're willing to say out in public that you do not need to do that because it does not happen anymore, then I'm fine with it. Okay? Until then, the manufacturer needs to supply the reps to cover the stuff. Otherwise, we can have inappropriate deaths on somebody who really needs a pacemaker, and the thing's reprogrammed itself. So you don't want to do that. Yes? The magnet? Okay, very good question. The magnet is used basically to change the modality of the pacemaker. Okay? The pacemaker basically can be altered in its programming based on the magnetic field around it. Okay? So when you see the pacemaker rep come by to interrogate the machine, they have this donut that they'll put onto the patient that looks like a donut. It's actually a magnet. Okay? And through that magnet, you can change the current through it to change the impulse conduction going to the machine, and you can actually reprogram it based on that. Okay? Now, what we can do is we can actually put a magnet over it to convert it into a certain mode. Okay? So we can activate it, or we can take an AICD and apply it, and you can hear the beep, and it shuts down the AICD. Okay? So it'll actually give you a sound when you're, and depending on which AICD rep, that's why I always call the reps and say, look, you come over and you do it, okay? Because every one is different, okay? And there's no standardization between one company to the next. So one company makes a sound, another company says, you know, put it on and leave it on. The other one says, put it on, hear the beep, then take it off. So what I do is I make sure that I call the rep and they come and see the patient and activate the AICDs. The reason you want to inactivate the AICDs is because when they start putting electrocautery, it looks like VTAC, okay? And the machine can't tell the difference, okay? So it fires the patient off, and it does it inappropriately. Yeah, you got a question? Yes, the wiring will clot at times, but it's rare, okay? What tends to happen with the wiring is that it endothelializes just like anything else. that's put inside the blood vessel. That endothelial layer will then protect it against clotting. So after a few weeks, the risk is very small. Not usually. They usually put them on it for about a week or two, then they stop after that. Now, what's interesting about these leads is that you can actually, this is a dual lead pacemaker. So it's in both the atrium and the ventricle. Okay? The way these actual wires are put in, see if I can show you a picture of it. Okay? It's not in there yet. But I'll get to that in a second. Well, I'll keep going here. This is what I expect you to know for the exam. 5-letter generic code is something you really have to know. You start having to understand this stuff. Because pretty soon, you're going to be doing open heart, and you're going to be asked, hey, look, I want you putting the patient on DDD or DOO, okay? And then you'll have to know exactly what that means, okay? The first letter denotes the chamber being paced. That's why the way I remember it is keep it simple, stupid, my thought, okay, is pacemaker. So where is it pacing, okay? So that's the pace is the first word, first letter, okay? Where the second letter is make. Where is it being made, or where is it being sensed, okay? So the second letter denotes the chamber that detects electrical signal. Yes? Yes. There's always a rep, pretty much in our hospital system, because we have, we're doing EP studies all the time, so we always have some reps that are around. Okay? But we have phone numbers to call them, and they come in. Okay? It's part of the requirement of their job to do that. And they're supposed to interrogate and making sure that the pacemakers. And what's really, it's now that it's becoming a nuisance to them, because they're putting so many pacemakers in. We're having so many patients go in with pacemakers that are coming out of the operating room. It wasn't that way before. They might have been called maybe once a month. Now they're being called almost once a day. So it's becoming almost a full-time job having to watch the pacemakers. But that's cost of their business. You know, they spent $40,000, $50,000 per pacemaker. So they got to take care of it. Okay. The third letter of response to sense signals. Okay, which is either I for inhibited. Usually the ones that we use is dual, which is D, which is dual inhibited and triggered, and O is no effect. Okay, the fourth and fifth letters usually, the fourth letter denotes the activation of rate response features, and the fifth position denotes the chamber in which the multi-system pacing is delivered. Okay, most of the time we use simply device the first three letters, and that's what I expect you to know for the test. If I tell you that you have an AAI, okay, that means you only have a pacer that's sensing in the actual atrium, and it only fires in the atrium. Okay. If we have a VVI, then we only have a sensing in the ventricle and sensing and firing in the ventricle. And you have a DDD, then you have both atrial and ventricle sensing with firing in both chambers. Okay. Most patients now that we implant pacemakers in, we find that it's helpful to have the atrial kick in the right place, and so DDD pacing is what we do. Now, trust me, sometimes you'll see that people do computations on figuring out what's the actual difference between P-wave to QRS, and they'll come up with this, standardized time. And this patient will actually do terrible with it. Okay? And you can see that in the operating room too. In the open heart suites, when you're pacemaking somebody, you're finding out that at the end of the procedure, you're pacing the patient, say, at a rate of 80, okay? And you've got your normal PR segment, PR interval separation, and the patient doesn't seem to be doing well. But every time you shut off the pacemaker for a few seconds, the blood pressure actually rises, and the patient does better at a slightly lower rate. Okay? What's happening is that even though you've set up to the adequate, PR segment, okay, or PR interval, what's happening to that patient is that you're either firing it too early or too late, the atrial, and you get inadequate cardiac filling. The heart, by far, has a much better system than we do, that we can electrically pace somebody to really determine what's the best PR interval. Okay? So sometimes you've got to play with it. I've seen some people really do bad with that until they get the right PR interval figured out. Okay? So that's something to be aware of. This is the device where you actually are going to play with. This is what we have here in our clinical arena here. Okay, that's our pacemaker. So it's not simple. Okay, it's a very complex pacemaker. So if you've never played with one, guess what? When you get to clinical, pick it up, look it over, okay, know how to use it. Okay, because if you don't, when you get open heart suite, okay, and they'll ask you, hey man, set it up, and you'll be going like, huh? Don't do that to yourself. So take some extra time, and there's plenty of downtime in certain times of the year. In the summertime is the time to catch up, read extra, take equipment, learn about it. Because when you have an emergency, that's the last moment you want to be having to learn how to use an equipment. Okay, you want to do it when you have time. Okay, so pick up one of these. We have the manual sitting in the main OR, so they'll help you go through the whole machine. Okay. These are pacemaker leads. These are implantable pacemaker leads. These have really been developed over a number of years. Okay, they actually have a little screw at the end of it that actually will allow it to be embedded into the muscle. So you'll see the cardiologist put it in, and then they'll turn it. What they're actually doing is when they're turning the wire, is they're rotating this screw and it's screwing it into the muscle. So this is not something that's just pressing against the muscle. It's actually being screwed into the muscle. So think about that. You're screwing in a little device into muscle that's pretty thin at times, so you can perforate the ventricle, and it can be very serious complications. Now, the other thing that happens in the old days was that even when the implanted electrode was perfect, okay, we would see that patients within a week or two would start getting problems with pacing. Okay? The reason that is because you're causing inflammation. You cause injury by damaging tissue. Okay? And that inflammation would actually cause swelling around the pacemaker leads, and then you would lose conduction. So these people that were in complete AV block, then all of a sudden they went back in the AV block a week later. So what these actual pacemaker wires, they're actually embedded with steroids. Okay? And by embedding the steroids, you decrease the inflammatory response, and you don't seem to have as much loss in conduction like they used to in the past. As you can see, the pacemaker wire is embedded all the way at the apex of the right ventricle, and that's where you can actually perforate through. Most of the time, people that do perforate will close up, and you'll have a small pericardial effusion, no big deal. But people that have dilated cardiomyopathies are much more at risk in the sense that their wall is so thin that when you tear it open, then you start leaking massively, and then they may code on you. Okay? So it's not a game. It's really pretty serious at that point. DDD pacing is atrial pacemaker output is inhibited by the intrinsic atrial signal. What these basically do is that if it finds that it has atrial, let's say a P wave is generated, the pacemaker will not fire. Okay? Then it waits for a certain interval time to see if a QRS is generated. If it is, then it won't fire. Okay? But if it doesn't see a P wave, it'll kick in, take over, fire the atrial lead, and then it'll wait again for the ventricular response. If there's no ventricular response, then it knows it has an AV block, and it'll fire the ventricular lead. So that way, it maintains its nice normal rhythm in this patient. If intrinsic, the important benefits of maintaining AV synchrony is that the atrial events either sense and pace, initiate, or trigger the AV interval is maintained over a wide range of heart rates. It permits the pacemaker to respond to increases in sinus node discharge, such as during exercise. In patients with sick sinus syndrome, it actually may contribute to a lower incidence of atrial fibrillation and thromboembolic events. And DD pacing also minimizes the incidence of pacemaker syndrome, which is an auto initiation without real need for it. Pacemaker symptoms is a patient will actually develop syncope, okay? A weakness, orthopnea. They also get like forms of congestive heart failure and pulmonary edema. The mechanism is due to loss of AV synchrony with resulting decrease in cardiac output. The loss of AV synchrony reduces the resting cardiac output by approximately 20 to 30%. And if somebody is very marginal already, you can have a very significant effect. It increases the atrial pressures and results in contraction of the atrium against a closed mitral and tricuspid valve due to the asynchrony, okay, and that causes the back pressure into the lungs, which is why you get the pulmonary edema and the PND. Okay. Symptoms of pacemaker syndromes are eliminated by pacing in a mode that restores AV synchrony. Okay. Now, DDI pacing is sensing in both the atrium and the ventricle, but only the response that is the sensed event is inhibited. Okay, so useful when you're doing frequent atrial tachycardias, which might be inappropriately tracked by the DDD pacemaker. So that's not usually used very often. This is what I expect you to know for your test as well. DOO. Okay. Why DOO? Because this is what we use in the operating room, okay, when the surgeon's beginning to close the chest. Okay. The reason we use DOO is because the surgeon is going to have to bovie the sternum as he begins to close it to basically stop the bleeding. They sometimes also will put wax on the sternum to stop the hemorrhaging, okay, because it leaks between the bone marrow and the sternum. So they'll bovie it, or they'll put bone wax, or they'll do both. When you put a lot of boving that close to the heart, it'll start, the pacemaker will start getting very erratic and actually will stop firing. And then you got a real problem now. You got no pulse at all. So we go into a DOO mode, which means it no longer senses anymore. It doesn't care. All it does is fires. Okay? Fire, 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 fire the whole time. Okay? So the heart continues. The inherent danger on this, okay, is what's called the R on T phenomena. Okay? If the patient has a R develops on his own and the pacemaker fires too soon, it will actually cause VTAC and then VFib. So make sure that you switch the patient back from DOO mode before you leave the OR to DDD mode. Okay, make sure you do that. Okay? There's been several reported cases of people going into VTAC from this failure to remember this. Then you have rate adaptive pacemakers, which I'm not going to go into a lot of detail. I just want to sort of give you an idea. But these things are not just simple. These are specialized pacemakers that actually will sense either temperature changes in the body. Some of them actually will sense the muscle movements in the pectoralis to basically indicate basal metabolic rate, and increases the pacemaker rate, thinking that it's exercising. And one of the biggest complaints that people have that are pacemakers is that once they get to start exercise, they sometimes feel short of breath because their cardiac output's not keeping up. So these rate adaptive pacemakers, especially for somebody who's really active, let's say if you have somebody who's young, let's say a 42-year-old that's just has a arrhythmia and really wants to go play tennis and stuff, then these rate adaptive pacemakers work well for them. Okay? The choice of pacing mode, most of the time we use dual pacing. DDDs is what we're trying to use nowadays. Okay? These are the actual different indications for doing it. Things that I want you to understand is that you can actually also do resynchronization therapy using biatrial or biventricular pacing. That's when you hear that you have to biventricular pace somebody, that means you're actually going to take a catheter and drive it through to the opposite side. So it inherently has much more risk. Okay? So make sure you be careful with those when you hear about them. Complications is what you have to know about, because guess what? You're going to have to sedate these people and keep them comfortable. The insertion complications account for about 5% of the complications. You may actually get a pneumothorax. Okay? These are implanted usually in the left side, okay? The left chest, okay? Usually the best location, because the wires don't have to, they can go much more directly to the left side. So a left subclavian vein insertion is usually where they put it in. If you get in too deep, you can get a pneumothorax fairly easily. Usually they're often small, and if you put somebody on 100% oxygen, it will help reverse the pneumothorax. Okay? But I've seen people get pretty significant pneumothoraxes from a pacemaker in the past. Okay? You may actually go into a tension pneumothorax as well. That's another thing that you have to consider. Watch what the surgeon's doing. Watch what the cardiologist is doing when they're putting that needle in. Okay? If they're going all over the place, you know, trust me, I've seen weird complications. I had one time an endotracheal tube in somebody. We were putting a pacemaker in them, and we saw blood starts coming out of the mouth a little bit. And ventilator started misfiring because we're losing a lot of volume. And we ended up finding out that we couldn't keep the air leak. We had a huge air leak. So we pulled out the endotracheal tube and reintubated the patient, which was not an easy task. And when we looked at the endotracheal tube, it actually had a hole in it from the needle. So we had actually inserted the needle through the trachea and hit the balloon and popped the balloon on the cuff. So you don't think those needles don't go everywhere. Think again. Okay. Air embolism may also be a problem. Air embolism is an issue, especially in cath lab, because those cath lab tables cannot go into a Trendelenburg position. Okay, so what they do is they actually only elevate the legs to try to improve venous return back to the chest. Okay? They're not deep Trendelenburg. If you're in deep Trendelenburg, the chance of you getting air embolism is almost zero. But being at the same height, or you're a little bit above the heart, you can actually suck air in. So you have to be very careful with that, especially patients that are really dry. And you're putting in cannulas as well to feed the wires through, and that can always suck in air. Okay? I've seen that happen too when you pull central lines out of people. The other thing that can happen is, of course, you're going to get a hemothorax. You can also get a pericardial effusion. Okay? Late complications, which account for about 2 to 7%, is pacemaker failure. It can occur more than 6 months after implantation. It's usually due to premature battery depletion, and then you have to look at basically replacing the actual battery, which basically we take the whole generator out and just replace it. The expected longevity usually is 5 to 9 years. Okay? But I've seen some people take up their batteries in 2.5 to 3 years because they're using it so much. The new improved shielding on the pacemakers has eliminated a lot of the problems. We used to tell people, hey, stay away from microwaves. We still tell them to stay away from microwaves. Most microwaves are pretty well shielded now as well, but just it can actually reprogram the pacemaker and cause problems. Okay? I always thought, well, you know what, if you have a bunch of pacemaker people around and if they ever do an EMP pulse from a nuclear weapon, all the people would drop dead, so you'll know who's got the pacemakers in. So that won't be shielded. Okay? So many artificial cardiac pacemakers are designed to convert to asynchronous mode. So when they're inhibited, the external field is encountered. So that's why we give that's why we put the battery on. The magnet on. That's what the artificial cardiac pacemakers are designed to convert to asynchronous mode. So it's basically going into a DOO. Okay, it's going to fire no matter what. Most pacemakers can usually be manually converted. Many functions of the artificial cardiac pacemaker can be adjusted using the magnetically activated potentiometer held externally near the pulse generator. Pacemaker malfunction can also occur, may lead to syncope, vertigos, and all sorts of problems. Sensing failures may also occur due to sometimes you'll get scarification around the actual pacer lead. And basically an EKG is not a diagnostic aid in this kind of pacemaker malfunction. You have to have the actual rep come and check it. So please don't think that just because you're doing an EKG that everything's fine. Okay? You may actually find out that the pacer is not even functional. Okay? So you have to have a pacemaker rep. Please always do that before surgery. They know so much. The pacemaker reps here know that we're pretty notorious about canceling cases if we haven't had somebody check the pacemaker at least a month before surgery. Okay? It's just not appropriate to bring somebody back to the OR and then get yourself into trouble and then find out that the pacemaker is not functioning. What are our concerns for cardiac pacemaker insertion? Is conscious sedation is usually what we do. Okay? Our EP lab, some of the guys don't want you to give any Diprovan. They just want you to give only Versed. So make sure if you decide to stay here that you look at all the protocols for who wants what. Okay? And that's pretty much what what's done everywhere else. Every surgeon, every cardiologist will have its own little pet peeve. Do I think Diprovan is dangerous in somebody with low EFs? The answer is no, as long as it's given carefully and slowly. It's not an issue. Okay? But it's just one more thing for somebody to blame us for. Drugs such as atropine, isoproterenol should be available, especially atropine. It's your friend. Isoproterenol may be something smart to use if you have a pulse. If you don't have a pulse, do not use isoproterenol as you'll kill the patient permanently. it causes so much significant vasodilation that you can't get the patient back from, even though you're doing effective CPR. Okay. Now, one of the things that you've got to do is if somebody needs CPR on those cath lab tables, we almost broke one the other day. We had somebody that weighed 350 pounds, and then we had somebody that was weighing 200 pounds doing CPR on top of them, which was me. That's a 550 pounds in weight that exceeded the cath lab table maximum weight limit. So you can get yourself into a bigger problem. You drop the patient on the floor. So when I did the first chest pump, the bed moved down about that much. I said, oops. So you got to move the patient down the bed first before you do effective CPR. Otherwise, you're losing all your energy into the bed. So I learned something new too. The actual bed, if you look at it, is really, really thin. It's almost a wafer thin, so they can X-ray through it. But when you start doing chest compressions, it's like doing it on a diving board. It doesn't work very well. You have your AICDs. These are things that are really saving a lot of people's lives. We used to think that we could treat arrhythmias with chemicals, which is what I showed you originally. Okay? The flecainide, the encainide, all those things were actually found to have a higher mortality rate. So because now we're implanting these automatic internal cardiac defibrillators. This is a pretty cool device. What the machine actually will do is it'll read the arrhythmia, it'll wait 15 seconds as it charges, and then it fires. And then it gets you out of hopefully it gets you out of the malignant arrhythmia. The thing that's bad about it is that if it misfires because it didn't read properly and you're awake, it's not a very comfortable feeling. And the anxiety level that it produces in some of these people can be pretty impressive. So some of them, I've actually seen them want the AICD pulled out. They said, I don't want to feel that. I'd rather be dead. That's what I've been told. So it's interesting. The AICD consists of a pulse generator, leads to dysrhythmia detection. It looks like basically a normal pacemaker. Okay? It has anti-tachycardia, anti-bradycardia pacing protocols in it. It does synchronized cardioversion as well. Okay? You can sometimes have, if you have an AICD in somebody, instead of externally doing it, you can actually have the pacemaker rep come over and synchronize it, okay, and fire it that way. So that's better for the patient because it requires a lot less joules and it's going directly to the heart. So be very, very careful about having to put defibrillating somebody or cardioverting somebody with a pacemaker. Do not put it over the pacemaker. That's bad form. You may actually burn out all the electrical circuits in it. Okay. Surgery in patients with cardiac devices, preoperative evaluation, determine the reason for the device, assess its current function. Perioperative planning should be coordinated with cardiologists and pacemaker rep. Okay? I always make sure that I do that. Okay? Make sure that you talk to the cardiologist that implanted it, or at least somebody who's following the guy, and make sure the pacemaker rep has seen the patient within a month beforehand to make sure that the pacemaker is either functional and the battery is not becoming depleted. Okay? AICDs are often switched off preoperatively and for therapy and reinstituted postoperatively. Many more IICD implanted as part of pacing and resynchronization therapy, so management decisions are now much more complex. So if you have an AICD in, but the patient requires permanent pacing, you have to have the rep come in and shut off the AICD component of it, but continue the pacing component. Okay, so make sure that they interrogate it and do it properly. Nothing worse than you shutting down both of them, and all of a sudden the patient goes from normal rhythm to basically bradycardia, and they go syncopal on you. That's not good form. Monitor the EKG for proper functioning, the pulse generator, ensuring the availability of equipment and drugs to maintain acceptable intrinsic rate. Okay. Be careful inserting PA catheters, as you may actually disturb epicardial electrodes, but they also may become entangled, which is a very dangerous part. If you become entangled in the wires, do not pull it out. Okay? Nothing worse than doing that because you can actually pull it out of the heart. That's bad form. Okay? If you feel like you have tension on pulling it back, get an X-ray, get a C-arm, look at it, see if it's wrapped around the wire. If it is, then it's not your case anymore. You got to send it down to radiology for them to help you. they'll take another catheter over the PA catheter and basically dislodge it for you. There's ways to do it, but it's not for you to do. Okay? You're going to get yourself in worse trouble. Most of the time that doesn't happen. If you're careful, if you put the balloon up properly, usually it's not an issue. Okay? The other thing, too, is it usually doesn't disturb the epicardial leads once it's been in over 3 weeks. Once it's in for 3 weeks, that wire's not coming out. It's pretty much scarred in. It's not moving. Okay? We don't even try to take out old leads. You know that? You know, we don't unscrew them. We just leave them in and just get a new wire and put it in right next to it. Okay? Because when you try to pull them out, you may actually disrupt the muscle of the heart. And also they're nicely epithelialized too, so there's no reason to pull them out. Okay? The drug of choice to produce anesthesia is not altered by the presence of a properly functioning artificial cardiac pacemaker, so you don't have to change your anesthetic management based on that. Okay? Improving shielding in cardiac pacemakers have reduced the problems, okay, with electrocautery. It's still, you have to be careful. Okay? If you have a choice, the favorite test question they ask you about pacemakers, what do you tell a surgeon to use for actual electrocautery? What's the preferred device? Bipolar device. Okay, instead of having one little, which is a unipolar, which is means that when you fire the electricity into the patient, the electrical current then is carried throughout the body, and what it looks for is a grounding plate. The grounding plate is basically this huge surface area that allows electricity to travel through it with the least amount of resistance so it doesn't burn the patient, and it goes out to the ground. Okay? If you have a bipolar, the distance is only between the two electrical poles, so it doesn't cause any disruption anywhere else. So you can be pretty close to the pacemaker with that kind of situation and not cause any problems. So if you do have to use the unipolar one, then you should try to put the pacer, the grounding pad, between the surgical site and the pacemaker. That's the preferred route. Okay, some people will put it away from it, but what they're actually telling us to do is put it in between the pacemaker. Okay, some of the books will recommend it that way, which makes sense. I mean, the electrode, that way the wire, it dissipates before it goes up. So. The basic external magnet should always be available, and you basically convert the pacemaker to an asynchronous mode. Make sure that you understand that it does carry the risk of RNT phenomena, so you may actually induce VTAC. The cautery is a device that we're talking about. The grounding electrode for the electrocautery should be as far as possible from the pulse generator to minimize detection of the cautery current by the pulse generator. Keep the electrocautery current as low as possible and apply electrocautery in short bursts. Okay? Don't let the surgeon go, that's like, that's not the way to do it. Okay? That's what's going to get you into trouble. Temporary transvenous cardiac pacemaking is something that we do once in a while. I've only had to do like 3 of these in my whole life, but when you have to, you really do need to know how to use them. They have little wires every 10 centimeters, so basically you put it in just like a PA catheter until you get pacing. Okay? Ventricular fibrillation in pacemaker, VFibs in patient with a permanent cardiac pacemaker is managed with a conventional manner. Okay? So an acute increase in stimulation may follow external fibrillation, causes loss of capture. In anesthesia, make sure you're prudent to avoid hyperventilation, as that can basically change your serum potassium concentrations, and that can cause significant arrhythmias. Succinylcholine can increase your stimulation threshold, and it can also inhibit the normal functioning of cardiac pacemakers, causing contraction of skeletal muscles. So that's a theoretical concern. Okay? Clinical experience suggests that succinylcholine is usually a safe drug, though, and especially if you have somebody with a full stomach, I still use it. Make sure that you avoid things like hyperkalemia, hypokalemia, arterial hypoxemia. All those are bad things that will actually affect the thresholds. Myocardial ischemia, infarction, of course, and catecholamines may also be a problem. Okay? All right, give you guys a 15-minute break. Okay? Start back up at 9 o'clock.